Just a very short remark for Dr. Falkenhorst about the schedule in France. This is the last schedule I give you. We have exactly what you say. We have recommendation, very precise, very acute, for pneumococcal on the last schedule of the April month. Exactly, with a free condition, not vaccinated, well vaccinated, and vaccinated with PPV3. With a free situation, what do you do? And the spacement is, for the moment, for France, 5 years. Yes.
Ah, okay. But just based on age, there's no recommendation, is that correct?
Recommend for all, we have tables for adults, healthcare workers, oldest, and we have all the vaccine.
Okay.
Especially for the subject, for pneumococcal, we have exactly what you say.
Okay, thank you.
WHO.
I give you. To see that.
Yes.
Hi, my name is Raúl Isturiz. I work for Pfizer. Up until 4 years ago, I was an opinion leader, and I was able to talk freely without my comments being interpreted as self-serving. And today, I'm really trying to do that. I'm really trying to make a comment that is not self-serving. But I remain extraordinarily concerned by the presentation by the German professor. Because, first of all, I detected several potential flaws in the interpretation of the data. But most importantly, the program in Germany seems to rely now very heavily on the completely unproven assumption that revaccination with a polysaccharide vaccine, with the consideration of hyperresponsiveness, et cetera, and double cost, each time you revaccinate, you spend more money, maintains protection. And my question is, how does short-term hyperresponsiveness offset short-term effectiveness? And how can a protection that has not been attained be maintained by repeated vaccinations? Every other speaker in the beginning of the morning showed that PPV23 non-PCV13 serotypes went up when a PCV13 program was instituted in children. And how can revaccination do anything about maintaining something that has not been attained?
Complicated. Okay, first of all, I agree with you that unfortunately we don't have any data to prove the clinical effectiveness of revaccination against clinical endpoints. So that's correct. But we do have data that show that with a one-time vaccination, you achieve protection for a few years only. So to not do anything after 5, 6, 7 years seems not a good idea. And as I showed you, most countries have already the recommendation to revaccinate for specific risk conditions, such as asplenia or immunosuppressed people or people with chronic nephrotic disease, and so on and so on. So what would be the rationale to say we do not recommend that for the elderly, just because they don't have any of these conditions? I think in the second part of your question or comment, you are trying to say that it has still not been proven that pneumovax is any good because the
if you see,
it didn't show an impact. When we talk about impact at the population level,
right?
Exactly. But if you have a program that only recommends a one-time vaccination, as our modeling showed, you cannot expect any impact because you are vaccinating at an age, 60 years or 65 years, where the risk of getting pneumonia is still quite low compared to the older ones. And those people are no longer protected when they come to the age of 75 or 80, when their risk is highest. So the incidence at the population level will not be influenced by a vaccination program that achieves maybe 50% coverage in 60-year-old people.
But you see a decrease in incidence in adult IPD and pneumonia, even in adults that are not vaccinated from the PCV13 vaccination in children. So you can measure that impact. But if you, analyzed the UK and recently Japan, those countries that have used PPV23 extensively have not only not shown a decrease they have not shown an impact on health in general in either country, but have shown an increase in serotypes in PPV23, not in PCV13. So the impact that you are seeing is from the PCV13 program and not from the PPV23 program.
Well, I think you also have to be very careful when you look at time series, because at the same time, I think the population of people above the age of 60 or 65 has much more comorbidities than it used to have 10 or 20 years ago. You have more people on immunosuppressive medication with biologicals and so on and so on. So all these factors would really have to be controlled for in order to make such a statement, I think.
Thank you. Gary Groman from World Health Organization. For Dr. Tan, just on influenza, fully agree with your comments on vaccine effectiveness, and just let everyone know, if you don't know already, WHO has instituted a committee which has got a lot of or most of the major editors of journals on board, where we're trying to introduce more rigor into the vaccine effectiveness reports. Because we feel at WHO, at least I'm sure most people do here, that these reports can be interpreted in many ways. So that's the first thing, and I certainly agree if it's, if you leave it on the shelf, then obviously you'll get zero, which I think is a really important point. But nevertheless, I think it's also important that there's a lot more rigor that goes into the science, and in particular the reporting of these studies, because they can be interpreted in so many ways, and really many of them are quite flawed in terms of scientific data and interpretation. But my question to you was really about repeat vaccination, the studies out of Canada, which I don't think have really been talked about yet here. Yeah. So that's something that's of great concern to us because, and we're analysing it carefully and trying to get more information, but let's say if it's true, and it seems possible, then what would the US position be? I mean, how would you implement a policy that vaccinates every second year?
It's a great question. So what we've seen from the data out of Skronci et al. In Canada is that even after the repeated vaccination, it appears that it is the immediate year before, and it appears that even after that, the titers, while they drop, and while the effectiveness drops, it doesn't drop to the point where it's actually worse than it's better than if you didn't vaccinate at all. You still want to vaccinate, right? So that's the driving policy decision. And again, I can't speak for the ACIP because I'm not supposed to, and I'm not going to. But I believe that will be one of the policy decision making will be the relative difference is if you don't vaccinate in the next year, what's the impact on the population in terms of protection against flu? And everything that's been published so far would suggest that even with repeated vaccination, especially the season before, the drop in effectiveness is still is not enough to obviously overcome the recommendation to vaccinate. And I think that's probably where we're going to head. But again, that's a prediction, a speculation on my part, and it will be up to the ACIP to decide, based on, again, those things I put up there in boxes.
Yeah, for Dr. Tan, you said how it is important to give surveillance and feedback. To come back to healthcare workers, I know, you know that there is mandatory vaccination in many hospitals in United States. I didn't find any data about nosocomial infection and the fact that these things, which are now for 3 years, give something. So I'm quite surprised about that. So I would like to have a comment because it's so impressive. You have the key to answer to the question, in fact.
That's a really good question, and it's a question I've asked myself. So I can give you my answer. So as Stefan has already pointed out, in the US, it's systems to systems, and actually our group, IAC, actually has an honor roll where we honor people who do mandatory vaccination and have rates over 90%. And just to let you know, there are more than 500 systems on that list already. So a lot of hospitals in the US are doing it. So here's the challenge, right? So you're right, we've got a great population to study, and I've gone to at least 3 of these systems and asked them, give me the data. Because if you give me the data, I will be able to tell the other systems that this is what they need to do. Their response is this, and so this is for this room, and I think this is the challenge is that, firstly, these are private institutions which have return on investment concerns. And so their point to me is, LJ, why would I spend a lot of money to do a study when I'm already mandating vaccination? It doesn't help me, right? It's true. If I'm already making it 100, if I'm already getting 99% of my healthcare workers vaccinated, I'm not going to do a study to show that. So one of the challenges I have, obviously, is getting them to do the study.
It's not an answer, sorry. The answer would be if they are private.
Mm-hmm.
So you have safety data about nosocomial infection to give to university, to give to institution. So we have to say normally how many
Correct.
nosocomial infection they are. You know, they are at 95%. Don't mind if it's 96 or 97.
Yeah.
Don't mind. But to say that there is very few nosocomial flu infection, and that's done. It's enough.
So, but the problem is with these institutions, they would have to start surveying for that, and flu is not, firstly, pediatric death is the only reportable condition for flu in the United States. So flu is not well surveyed for in these institutions in terms of nosocomial infections. So they would have to start up a system to do that, which they don't want to do. But the very first organization in the U.S., the Beverly, it's the Virginia Mason's hospital system in Seattle. They are actually about to submit a publication on that data because I kept pushing them. So hopefully we will see that publication soon. But you're absolutely right. It's about getting the data.
2 more questions and then we will stop because.
Thank you. Christian Teilaka from Pfizer again. So I have a question for Gerd Falkenhorst. First of all, I would like to congratulate the STIKO that they did a very rigorous process. They did a meta-analysis which is published, and not a lot of vaccine technical committees have done that. However, I think it's important to, meta-analyses are only as good as their input. And you have to look closely at the study methodology of the studies that you use. You have 2 studies two RCTs that you used. One, and I think important detail was lost, which was 95% of your cumulative effectiveness, was done in nursing homes. And the age of these patients, median age, was 85-year-old. So these were very old patients. The question is, are they representative for the plus 60 or plus 65 population? And then you had in the study an effective efficacy against all-cause pneumonia of, I think, 40%, and efficacy against pneumococcal pneumonia of 65%. Now, these numbers don't add up unless you have a huge proportion of pneumonia being due to pneumococcal pneumonia. So there is something that doesn't add up in this study. And just on this other trial that you included, so these patients were to a large proportion below the age of 65. 1/3 was below the age of 65. These were all COPD patients. And this study actually did not meet a lot of rigorous criteria for an RCT. No inclusion criteria, no clear definition of the cases, and so forth. So the question is, if you want to hinge your recommendation on those 2 studies, and maybe on observational studies, but that's a whole different issue because there's lots of unmeasured confounding going on in observational studies, are you sure that you're measuring what you want to measure?
Yeah, I mean, this is life. The data that you have has never the quality of data that you want to have. And maybe I should really make it clear that I do not believe that PPV23 is a great vaccine. And I believe that PCV13 is a great vaccine for children. Yeah? And if you had a conjugate vaccine that would have the same serotypes included, compared with the polysaccharide vaccine. I guess the conjugate vaccine would be better. But the problem is, I mean, the PCV13 in the infant vaccination program is so effective and has such a strong herd protection effect for all age groups that it simply doesn't make sense to vaccinate the elderly with the same vaccine when these serotypes are disappearing. Why would you vaccinate against a disease that is disappearing due to herd effects from the childhood vaccination program? But to come back to your question or to your remarks about the studies by Maruyama and Alfageme, it's correct that the Maruyama study, well, this is going into detail now. I don't think that is good for everyone. We can maybe discuss that. But yes, if it is very old people, if it works in very old people, you're right, they are not representative of the target population that we have. But we discussed it, and we didn't see a reason to assume that in younger old people with fewer comorbidities, it should work in a worse than in those very frail old people. On the other hand, I could give you back the comment that the CAPITA study was done in immunocompetent elderly people only, so it was an exclusion criterion if someone was immunosuppressed, and this is not the reality. In our target population above 60 years, I don't know what, but 10, 15, 20% of people have some sort of immunosuppression. And then also that's why I represented the results of the modified intention to treat population. I really find it a bit unusual that you have a per protocol analysis where you exclude people who were meeting your inclusion criteria at the time of inclusion into the study, but who then afterwards developed an immunosuppression between the time of vaccination and the time of developing pneumococcal illness. I mean, I cannot tell my patient, sorry, you are no longer meeting the criteria for the vaccine. I think so. I think it's good that you also publish, or that that Bonton published the modified intention to treat analysis, which I think is giving a more realistic picture of what we can expect for our patients. So let's have a higher valent conjugate vaccine, please.
We have a last question.
My name is Rick Bogarts. I'm working on vaccines for 3 decades or so, mainly with large companies. I'm here for Takeda, but I don't have a question. I just want to illustrate something that is, I think, rather important for all of us. When in 1974, WHO installed their enlarged program of immunization, they said that 20% of the success of vaccination is about the vaccine. We talk here a lot about the vaccine. 80% is about implementation, and that was a very welcome aspect that was just added by a very great speaker. The new version of this, I think, is that 20% is still about the vaccine, and we know how to do that. 80% now is about communication. And I would like to challenge a statement that is, I'm not sure it's launched here, but we hear it too often. And I challenge it because it doesn't help us with vaccination. And it's when we say that we start aging as soon as we are born. I don't think it is correct. When we are born, we are incomplete beings that need another decade and a half, probably, to become at our best, mentally, physically. Then we stay more or less stable, if we are lucky, for another 30, 40 years. And then starts what we call now aging in various degrees of acceleration. If we translate this to vaccination, then childhood vaccination offers our children the possibility to not be taken away by infectious diseases before they get this opportunity to really grow to full-grown human beings. Booster vaccinations will help us to go through this steady state. And then we arrive at a vaccination that is the subject of our conference today, which is vaccination against specific conditions that attack us as from the age of 50 and older. So let's not say that we are aging as soon as we are born. Fortunately, it's not the case.
So